Hello, my topic is Vedolizumab versus Adalimumab for moderate to severe ulcerative colitis. Definition: Ulcerative colitis is a chronic inflammatory disorder of the large intestine characterized by abdominal pain, bloody diarrhea, and fecal urgency.
What is ulcerative colitis? Ulcerative colitis is a chronic condition characterized by inflammation and sores or ulcers in the rectum and colon or large intestine. Ulcerative colitis can be distinguished based on how much of the large intestine is involved. When ulcerative colitis involves only the rectum, it is referred to as proctitis. If the left side of the colon is involved, it is known as left-sided colitis. When the entire colon is involved, it is known as pancolitis. Ulcerative colitis is characterized by periods of time with active inflammation when the patient is experiencing symptoms, and periods of time when the inflammation is turned off and the patient feels well. We call these periods of wellness remission. Many patients with ulcerative colitis have long periods of remission, alternating with periods of active inflammation, which are called flares. Some patients with ulcerative colitis have more severe flares than others. Although the cause of ulcerative colitis is not known, many factors can contribute to a person's risk of having ulcerative colitis, but most can be thought of in three categories: genetic predisposition, environmental factors, and a dysregulated immune response in the GI tract, which causes the inflammation. Environmental factors may include infections, smoking, and taking antibiotics or non-steroidal anti-inflammatory drugs, or NSAIDs. In ulcerative colitis, inflammation appears within the colon, and the immune system works to combat the bacteria and viruses as it does with a cut on the surface of the skin. However, the difference is that the immune system is not able to turn itself off after it rids the body of the bacteria or viruses, so the ulcers remain until they are treated with medicine or surgery. This chronic inflammation is what causes the symptoms of ulcerative colitis. In ulcerative colitis, the rectum, the last 6 inches of the large intestine, is always involved. The inflammation may involve additional areas of the large intestine above this area. In some patients, the inflammation may extend further up into the colon, and it is thought that in some patients, the inflammation extends higher up over time. Approximately half of patients who do not have the whole colon involved at the time of diagnosis eventually progress to more extensive disease, which may result in new symptoms or loss of response to an existing therapy. Most of the symptoms of ulcerative colitis are related to the inflammation of the rectum. When the rectum is inflamed, it is not able to store contents or distinguish gas from liquid. Because of this, patients frequently feel the urge to run to the bathroom or fear that they will leak or have an accident. Other symptoms of ulcerative colitis can include frequent small stools, fatigue, low energy, and rarely fever. Because the rectum is always involved in ulcerative colitis, patients usually experience similar symptoms regardless of how much of the colon is involved. In addition to symptoms involving the colon, ulcerative colitis can affect other parts of the body. Symptoms outside of the GI tract can include joint pain, liver inflammation, osteoporosis, skin problems, eye problems, mouth ulcers, and anemia. Patients with ulcerative colitis should expect to lead normal lives. An important goal of the healthcare provider is to help people manage the disease, rather than having the disease manage them.
Adalimumab is a humanized monoclonal antibody that binds and neutralize TNF. It is widely used to treat ulcerative colitis, intestinal colitis, anti-enegrin. Vedolizumab is a humanized monoclonal antibody that specifically binds to leukocyte integrin alpha 4 and beta 7. Application in nursing. Screening evaluation, including a physical exam, taking viral signs, endoscopy, stool and blood tests, tuberculosis detection. Pros and cons. Pros. The drug vedolizumab modifies the entry of inflammatory cells into the intestine, and adalimumab it can be used shortly after diagnosis if you have a disease or if you have a more severe Crohn's disease, and in turn can reduce signs and symptoms. It can also be used after other medications have failed to control symptoms. Cons. Vedolizumab does not bind to the alpha 4 and beta 1 and alpha E and beta 7 integrin or inhibit their function. Likewise, induce alteration in systemic immunosuppression, a effect that does not affect the immune surveillance mechanisms of the central nervous system. However, adalimumab carries a small risk of complication, including tuberculosis and serious fungal infection. The most common side effects on adalimumab are skin irritation and pain at the infection, sick, nausea, runny nose, and upper respiratory tract infection.
Hi, my name is Bruce Sands. I'm the chief of the Division of Gastroenterology at Mount Sinai Medical Center in New York, Icahn School of Medicine at Mount Sinai. And I'm talking about a publication about vedolizumab in patients with Crohn's disease, published in Gastroenterology. Vedolizumab is an investigational agent that was recently approved for the treatment of Crohn's disease and ulcerative colitis, and it's a different biologic agent in that it targets alpha-4 beta-7 integrin. Therefore, it interferes with lymphocyte trafficking to the gut. In the Gemini 2 study, this agent proved to be effective for induction and maintenance therapy in patients with active Crohn's disease who had failed other therapies. This study looked at patients who had prior treatment for their Crohn's disease who had moderately to severely active Crohn's. These were adult patients between 18 and 80 years of age. They had Crohn's disease diagnosed at least 3 months, and they all had moderately to severely active Crohn's disease as defined by a CDAI between 220 and 400 at screening, and they also showed biologic indicators of inflammation, including an elevated C-reactive protein or colonoscopic findings of active Crohn's disease, or a elevated fecal calprotectin of more than 250 micrograms per gram of stool. All of them had active disease in the ileum and or the colon, and all of them had inadequate response or intolerance within 5 years to an anti-TNF and or immune modulators and or corticosteroids. The emphasis of this study was on patients who had prior treatment with anti-TNFs, which comprised 75% of the treated population. The study design was very simple. It included a 1-to-1 randomization stratified for prior anti-TNF failure. and patients were assigned to 10 weeks of active treatment and were given either placebo infusion at weeks 0, 2, and 6, or were given 300 milligrams infusion of Vedolizumab at weeks 0, 2, and 6. The primary endpoint was at week 6, and a secondary analysis was done at week 10. The primary efficacy endpoint was clinical remission as defined by a CDAI of less than or equal to 150 at week 6 in patients who had had prior anti-TNF failure. However, predefined secondary endpoints included clinical remission at week 6 in the overall population, including both anti-TNF naive and TNF failure patients, and clinical remission at week 10 in the anti-TNF failure and overall populations. 416 patients were enrolled, including 315 patients who had prior TNF antagonist failure and 101 patients who were TNF antagonist naive. More than half of the patients had corticosteroid use at the time that they were enrolled in the study. About 1/4 to 1/3 of patients were on concomitant immune modulators. And in the TNF failure population, all the patients had prior anti-TNF experience. And in the overall population, 75% had prior anti-TNF experience. The median CDAI for this population was moderately severe at roughly 314. The primary analysis was clinical remission, or CDAI less than or equal to 150 at week 6. And this was not achieved in the primary efficacy population of the anti-TNF failure patients. 15.2% of patients assigned to Vedolizumab achieved clinical remission at week 6, as compared to 12.1% in the placebo-treated patients. In the overall population, however, 19.1% achieved remission at week 6, as opposed to 12.1% in the placebo-treated patients. However, looking at the secondary analysis at week 10, clinical remission was achieved in the TNF failure population in 26.6% of patients, as compared to 12.1% of placebo-treated patients, for a statistically significant difference. So thus, while the study was a failure in terms of its primary analysis, the secondary analysis was revealing in that patients extended on observation to week 10 actually achieved very good remission rates that were superior to placebo. So the take-home message of this study is that for patients with Crohn's disease, and particularly for patients who had prior anti-TNF failure, there's a need to wait a little bit longer for patients to respond and remit. Probably patients should not be considered to have failed treatment until they've been followed out to at least week 10 if they have Crohn's disease and prior anti-TNF failure. The safety data also was consistent with the Gemini studies. No new findings were found, and to date, no cases of progressive multifocal leukoencephalopathy, or PML, have been observed. So that's the summary of the study, and I appreciate your listening.
I should apply in Ecuador. Globally, there has been an increase in cases of inflammatory disease in its two varieties, both in ulcerative colitis (UC) and Crohn's disease (CD). The hospital where the most cases of UC were treated was Teodoro Maldonado Carbo from Guayaquil and for Carlos Andrade Marin from Quito. Regarding biological therapy, the data show that its use is higher, is thus affected by CD versus UC 45% and 31%, respectively. Therefore, we determined that in Ecuador, the use of biological therapy differs between the centers in which the study was conducted. Conclusion: the current use of Vedolizumab tends to be in adult patients with active ulcerative colitis moderate to severe, who have had inadequate responses, have loss of response, or are intolerant to conventional treatment or anti-TNF with low response possibilities. Even so, in several studies, it has been shown to be effective with a low rate of side effects. Probably in the future it will be used earlier to increase the subject rate.
And I'm a gastroenterologist in Minnesota. I'm a gastroenterologist that specializes in treating patients with Crohn's disease, colitis. Last week was very exciting in that there were 2 new papers that came out in the New England Journal of Medicine in regards to a brand new therapy for both ulcerative colitis and Crohn's disease. Now, what makes this new therapy different is that it has a completely different mechanism of action than any of the other therapies that are currently available. It is a monoclonal antibody, so it is under the realm of these biologics, but it is not like Remicade, it is not like Humira or Cimzia. It is completely different. It is given as an IV, but works differently. And how does it work differently? It actually is targeted to the gut, which makes it that much nicer and probably safer. So the 2 papers, one for Crohn's disease and one for ulcerative colitis, showed that these were better than placebo in treating patients and getting active symptoms under control. Now, it's interesting that the patients who had ulcerative colitis did better on this therapy than those with Crohn's. And it's a little unclear right now why that might be, except that we know that ulcerative colitis is a condition that is limited to just the colon, which is where there's a lot of lymph tissue and where this therapy is particularly targeted. So we're all very excited about these new data and this new mechanism of action and this new therapy. It's going to take probably another year or up to even 18 months to see this on the market, but the data as published now in the peer-reviewed realm is very exciting, and now we can move forward with trying to get FDA approval of this and offer patients yet another choice for trying to treat their disease.